Good evening, ladies and gentlemen, and welcome to usmlevideos.net. On usmlevideos.net, we post a video every day, and we also recommend you to subscribe to our videos so that you can get a new USMLE video in your box every morning. Tonight, I want to talk a few minutes about subarachnoid hemorrhage. In fact, this morning I got a patient with subarachnoid hemorrhage, and that's another reason that I chose to talk about this topic tonight. Subarachnoid hemorrhage is simply bleeding into the subarachnoid space. Most commonly, like in 75% of cases, it happens due to the rupture of berry aneurysms. In subarachnoid hemorrhage, you need to remember tons of questions come from this topic, and every point is important. Now, in some 10% of cases, AVMs cause subarachnoid hemorrhage. AVMs are simply arteriovenous malformations. They are actually conduits of blood vessels between arteries and veins bypassing capillary bed. So these AVMs cause like 10%. But subarachnoid hemorrhage due to berry aneurysms, it usually manifests in 5th or 6th decades, whereas subarachnoid hemorrhages due to AVMs, they manifest much earlier, like 2nd to 4th decades. Now, the distribution. Most of these berry aneurysms are distributed in either in middle cerebral artery or anterior communicating artery, and most of the AVMs are located in the middle cerebral artery. Now, the circle of Willis, that is a major circle that forms the cerebral vessels. Around the circle of Willis, most of these berry aneurysms, they manifest. Now, the other important things we need to think about is which patients have that highest incidence of berry aneurysms. The answer is polycystic kidney disease and coarctation of aorta. They might present in association with berry aneurysms. That's why it is important that you think about berry aneurysms whenever a patient with polycystic kidney disease present with subarachnoid hemorrhage. Now, some patients like endocarditis, they present with mycotic aneurysms. That happens in minor cases. Now, pathophysiology. Rupture of intracranial artery, it causes increased intracranial pressure. This is the cause that patient with subarachnoid hemorrhage says that he got the worst headache in his life, because intracranial pressure, it elevates because of the rupture. And this is also gets manifested in the eye. In the eye, in the retinoscopy, you see subhyaloid retinal hemorrhages. That is also a very important point. Now, let us talk a few minutes about clinical findings. The most important clinical finding is headache, severe headache. Patient says, this is the worst headache I ever had in my life. Now, some cases may not present with severe headache. Example, AVM caused subarachnoid hemorrhage. In AVM caused subarachnoid hemorrhage, the headache may not be that severe. Then patient may have loss of consciousness at the onset of subarachnoid hemorrhage. He may also present with vomiting and neck stiffness as meningeal irritation happens. Now let us think about other effects. As the blood accumulates in the subarachnoid hemorrhage, it causes chemical meningitis. This chemical meningitis causes meningeal irritation, and the signs of meningeal irritation like neck rigidity can be seen. You remember Brzezinski's sign. Brzezinski's sign, you go to the patient and says, sweetie, I want to test you a bit, just flex your neck. And while flexing the neck, you look at the hip and if the patient flexes his hip, that is a positive Brudzinski sign, which is characteristic of meningitis or subarachnoid hemorrhage. So that is an important sign in these patients. Now, whenever patient presents with oculomotor nerve palsy, these are actually incidental findings. Whenever this palsy happens ipsilateral to posterior communicating artery aneurysm, subarachnoid hemorrhage is associated with oculomotor nerve palsy, and it can also be associated with abducens nerve palsy. And ruptured AVMs may also present with focal signs like hemiparesis, aphasia, and defect of the visual fields. Now, laboratory findings: you must always order a non-contrast CT scan of head whenever you suspect subarachnoid hemorrhage, because in most cases, like 90% of patients, that is the gold standard, non-contrast CT scan. You can also order MRI, but it is costly and laborious to do. But MRI is better to see AVMs. And also, once the patient is stabilized, you can order arteriography to see where exactly the patient has aneurysm. And then in the CSF examination, once you do CT scan and you cannot find subarachnoid hemorrhage on CT scan, go for lumbar puncture and look at CSF. CSF will be grossly bloody, and you can also see xanthochromia because of the rupture of blood vessels, RBCs. Now let us talk a few things about the treatment. In the treatment, the most important thing is stabilization. These patients presented with increased intracranial pressure. So you need to reduce the swelling in the brain. That's why you do not just pump lot of IV fluids in these patients, because IV fluids, they only worsen the brain swelling. You should keep the patient you should only give isotonic IV fluids in these patients. And the other thing is bed rest, give analgesics for headache. These patients present with hyponatremia that might be part of cerebral salt wasting. So you treat hyponatremia with NaCl or 3% NaCl, but not with fluid restriction. And many of these patients go into vasospasm. That's why after subarachnoid hemorrhage, you treat vasospasm with nimodipine. That's very, very important point. Using nimodipine, the calcium channel blocker, in order to reduce the vasospasm. Then you can also start these patients on phenytoin, because many of these patients, they get seizures. So you are preventing seizures by using phenytoin. So basically, you stabilize the patient. Then if the aneurysms are big, you need to think about surgery. If the patient has AVMs, you need to think about surgery or embolization of that particular part of AVM. And for surgery, we usually grade subarachnoid hemorrhage into 5 grades: grade 1, 2, 3, 4, and 5. 4th and 5 are stoporous and coma. So only in 1, 2, 3 you think about surgery as the treatment. In 4 and 5 you do not do surgery because the mortality rate is very, very high. So those are the most important points I want to talk this evening. And if you have any questions, just send me. And if you have any important points, just send me an email at www.usmlevideos.net. Thank you.